It's okay. No, that's fine. I'm going to go back. Okay. So as you see, pulmonary artery catheter is a long catheter with a different port, and each port has a different length. So by knowing that each port is and which part of the catheter can help us to use the different of that. So the blue port, that this one, is terminating the 30 centimeter. And if we float the swan and the tip of the pulmonary artery catheter being a pulmonary artery, then we expect that the blue part, the hole, be open in the right atrium. In this way, we can measure the central venous pressure and right atrial pressure. The red and white connector includes a temperature-sensitive wire that terminates 4 centimeter proximal to the tip of the catheter. Why we need a temperature-sensitive wire? Because one of the way we can calculate measure the cardiac output based on a thermal dilution. So we need some sensor to measure and sense the changing in the temperature. The white port acts that terminating a 31 centimeter, and this one used as a side port. Some of the pulmonary artery catheter doesn't have a white port, but you can give the blood, you can give a fluid, you can use as an access. The yellow, this one, that end up with the tip of it and has at the tip we have a balloon and is going to measure the pulmonary artery pressure. And the red one, that this one, is connected to the balloon that is on the tip of the catheter, and we can inflate and deflate. The syringe that comes with a kit, you can just give a 1.5 cc of the air. Is a special syringe. You cannot give more than that. And my recommendation to you is that, except that the first time that you inflate, inflate the balloon and float the swan. After that, anytime you want to measure, just give a 1 cc first. Because by different things, the tip of the catheter can move back and forth. And if the tip of catheter advance and you give a 1.5 cc, you may actually rupture. So give a 1 cc and look at the tracing. If with a 1 cc you can wedge, means that the tip of the catheter is too far, you need to pull back. But if with a 1 cc you cannot wedge, then give another ½ cc. This is some kind of safety for you to prevent of the damage. So let me show this video that they actually float the swan.
This is a demonstration of Footformat.
In the beginning, we insert the catheter. After we put a cortis, we insert 20 centimeter. Then we inflate. We give a 1.5 cc and inflate the balloon and the advance. With a blood flow, the swan would float it, going past from the right atrium to the right ventricle. As you see, look at the tracing. So later I explain to you, but when you reach to the right ventricle, the systolic increase and the diastolic stay the same. But by the time we advance and float the catheter, the diastolic change. And the tracing, you see, you can see the dicrotic notch. That's the time you advance to the pulmonary artery. And if you little bit, when you see the tracing of the pulmonary artery with a dicrotic notch, stop here. You don't need to advance unless you want to wedge. And then after that, you millimeter advance it to see that if you can wedge or not, and then you can deflate and pull back and keep the catheter there. Maybe I show one more time, and then I go continue my presentation. Just look at the tracing again. So this is a right, we inflate with a 1.5 cc. Is in the right atrium, so we can measure the CVP here and right atrial, and you see the tracing of right atrium. If you can see the, later I'll show you can see the A, C, X, and V on the CVP tracing. And then you go to the right ventricle, different systolic change. So normal systolic is between 20 to 25. Diastolic stays 0 to 5, the same. And then goes to the pulmonary artery. The moment that goes to the pulmonary artery, you can see the dicrotic notch and change on the diastolic. The diastolic increase to normal is between 12 to 18. And then if you advance a little bit, you can see the wedge pressure. Okay. So as in the video, you saw that right atrium, that the tracing, right ventricle, pulmonary artery, and wedge pressure. So what the pulmonary artery catheter we can do with that? With the pulmonary artery catheter, we can measure directly central venous pressure, right-sided intracardial pressure, pulmonary artery pressure, pulmonary wedge pressure, cardiac. We can calculate the cardiac output based on the thermodilution, and we can measure the mixed venous. You can measure the right ventricular pressure just when you insert the catheter. The moment that you float the catheter, you can measure the right ventricular pressure. Other than that, you cannot measure the right ventricular pressure. Or when you want to remove it, if you slowly remove the catheter. Indirectly, you measure the systemic vascular resistance. If you prepare for board, prepare this formula, because there is a chance you get a question about that they ask you to calculate, to measure the systemic vascular resistance or pulmonary vascular resistance. So you need to know the formula. And then cardiac index and a stroke volume index. So cardiac index is the cardiac output divided by body surface area. There are the two ways we can measure the cardiac output in the cardiothoracic ICU that I talk about the both two ways in my next few slides. So the way that we measure the cardiac output is based on the principle of dilution. If we know the quantity of an indicator injected to the blood, by how much it changes, you can measure the blood flow. In a thermodilution, we use the cold solution. However, the study showed that the cold solution versus the room temperature solution doesn't difference that much. So we use the room temperature solution. We give it 10 cc. So then we create a thermal deficit as a variant of indicator, and then based on we measure the cardiac output. So the tracing that you see is that the cardiac output properties inversely related to the area under the curve. So if the area under curve is smaller, the cardiac output is higher. If the area under the curve is higher, the cardiac output is less. So why is that? Because how fast, if the patient has a higher cardiac output, the temperature change faster compared if the patient has a low cardiac output. As you see, the tracing, the patient in A has a better cardiac output compared to the patient on a C. And also, they may give you the tracing for the cardiac output and may ask you that which patient has a higher cardiac output. The other way we calculate the cardiac output in the CSICU is that we use the Fick formula. What is the Fick principle? The Fick principle relies on the total uptake of the substances by peripheral tissue is equal to the product of the blood flow to the peripheral tissue and the difference between arterial and venous. So what does it mean? Means that if we know that they use on a Fick formula in the cardiothoracic ICU, we use the mixed venous. What does it mean? Means if we know the difference of the arterial and mixed venous saturation, and we know by the fact that if the patient is 70 kilograms at the rest, the oxygen consumption is 250 cc per minute, based on know that in a normal situation, patient use the 250 cc oxygen per minute, and you know the difference between arterial and venous, you can calculate the cardiac output. But even for the fixed formula, there are many different things. Is really our patient that after surgery, sepsis, are they really using the 250 cc oxygen per minute? We don't know, but this is the only thing that we have it. And for the thermodilution and cardiac output, I'm talking in my in next few slides that many different things can affect on all those pressure that we measure in the pulmonary artery catheter. So that's true. There are the numbers we get sometimes may be tricky, but if you know, then you can interpret the way that that's helping you. So clinical use of pulmonary artery, so we can differentiate the different type of shock, cardiogenic versus hypovolemic versus distributive or obstructive. You can differentiate between cardiogenic, non-cardiogenic. For the pulmonary hypertension, if the patient has a high pulmonary vascular resistance or not high pulmonary vascular resistance, they can differentiate to you. Diagnosis of precardial tamponade, left to right cardiac in, cardiac shunt. So the contraindication for pulmonary artery catheter is coagulopathy, infection, if the patient has an RVAD or a right ventricular support, if the patient has Eisenmenger syndrome, left bundle branch block, because there is a chance you just make the right bundle branch if the patient has a left bundle, so you make a complete heart block. And if the patient has a prosthetic or stenotic tricuspid or pulmonary valve, and if the patient has a mass. So complication can be arrhythmia and misplacement, knotting, pulmonary artery perforation, pulmonary infarction, thromboembolism, infection, and data misinterpretation. Why I put the data misinterpretation? Because the reason that now they don't use pulmonary artery catheter in the other ICU besides that the cardiac ICU or CCU is that actually they did a study, and one of the studies they did at Mount Sinai, the person that taking care of these patients, they don't know how to interpret the data and they don't know how to take care of the patient on a pulmonary artery. It happened to me, and they asked me to go see the patient that has a pulmonary artery in the other ICU, not cardiothoracic ICU. And they asked me that the tracing that they see doesn't look like this doesn't look like the tracing that they should it be. Then I went, the only thing that I did, I just deflate the balloon. So it means that someone, I don't know when, how many days ago, come, inflate the balloon and left it there. That's the reason that, because we insert less swan, so we don't know how to manage the swan and we don't know how to interpret. But I can say if you know that how to interpret the data, if you know how to take care of the pulmonary catheter, and if you know that the things that can affect the numbers actually is helping you. That's true. Pulmonary artery catheter is not telling you about the volume status, but it's telling you about the pressure. It's telling you about the right arterial pressure. It's telling you about the pulmonary artery pressure. You can measure the mixed venous. So there is an important data that you can help, but you need to know how to interpret those. And Usman, please, anytime if you want to add or say something, feel free, because it's hard for me to talk about the pulmonary artery in front of Usman, but but please feel free. Please feel free anytime you want to say something. Okay. So I didn't brought any study because there are tons of study observational, randomized, meta-analysis. They show that there is no benefit, but there is no benefit because we don't know how to use it and we don't know how to interpret. But if we know, it's useful. And then I want to emphasize, case by case, you can make a decision to put a swan and then differentiate why the patient is in a shock. You need to think about the risks, the complication, and then use the swan. So now I'm going to talk about the different tracing you see on the pulmonary artery catheter. And as I said in my beginning of presentation, most of the time we may not change our management before a tracing, but sometimes by look at the tracing also it can confirm what you're thinking. For example, if the patient has an MR or if the patient has a TR, I just look at the tracing can help you to confirm that this patient. But this definitely is helping for you for the board question and exam. So as for the tracing the CBP, I know you heard before, just repeating and refreshing your memory. So there is a different part of this tracing. The A part is atrial contraction. That's the time is that there is an increase in the pressure in the CBP because of atrial contraction. And then the pressure drop, a little bit increase the pressure because of the tricuspid valve closure. And then is the atrial diastolic. And then this is a passive atrial filling and then atrial emptying. So then I show you that if they be abnormal, why is abnormal and how you can differentiate. So this just with the EKG and the CBP tracing. So you can expect the A is atrial contraction, so expect it's coming after P, and then this is a closing of the tricuspid, and then this is a getting empty, passive feeling, and then relaxing. So when the right atrial pressure is high, can be because of the right ventricular failure, can be because of the left to right shunt, tricuspid valve disease, cardiac tamponade, constricted pericarditis, restrictive cardiomyopathy, hypervolemia. But I understand hypervolemia is not necessarily the CVP because the pressure is never the volume. Always compliance is in this between that we need to pay attention to that one. But if the patient CVP was 8, the patient post-cardiac surgery, the CVP was 8, and then all of a sudden CVP is 16, 17, we should think what happened? That all of a sudden, without changing the pressure, change the tamponade? What happened to the patient that CVP, or is the right ventricular failure that the pressure all of a sudden increased and patient now is hypotensive? So in a CVP tracing, if we have a tall V wave, is indication of the tricuspid regurgitation. So the next time if you are in a CSICU and you know the patient has a TR, just look at the tracing. You can see the tall V on the tracing. And if the patient, I showed the giant and Canon A wave in my next slide, that then the atrioventricular dissociation, you can see Canon A wave, or simultaneous contraction of atrium and ventricular white tricuspid valve is closed, like complete heart block, tricuspid stenosis or AV node tachycardia, and loss of A wave in an AFib or A flutter. So this is the one that you have. You see the tall V. So when the patient has a TR, this is the Canon AV. When there is a dissociation between A or V, like a complete heart block. And now I'm talking about right ventricle numbers and tracing. So as I said, pressure can be measured during the insertion, and after that we cannot measure the right ventricular pressure. Normal pressure is between 50, systolic usually is 25, diastolic between 3 to 12. Then elevated right ventricular pressure can be because of pulmonary valve disorder or right ventricular disorder if we have a cardiomyopathy and the compliance in the right ventricle change. So for the right ventricular tracing, you just see when you insert and then just quickly, we have a rapid filling and then we have a slow filling. This is the atrial contraction. This is the end diastolic and this is the systolic. Just look at, this is a normal wave. And then here I put a different one to compare. So like as an atrial fibrillation, we lost A. In atrial flutter, we have a sawtooth. In complete heart block, you can see that like an AV dissociation, so the A can be different. And then in a tricuspid regurgitation, we have a tall V. Because I talk about precordial and tamponade and constricted pericarditis later. So In a pulmonary artery catheter, so as we talk about it, when we advance the pulmonary artery, systolic stay the same, so 15 to 25, but then diastolic is higher, usually between 12 to 15. Mean arterial pressure is usually between 10 to 22, average 16. Anything more than 25 is a pulmonary hypertension. Increase in pulmonary artery pressure can be because of the thromboembolism and because of hypoxemia, because can cause pulmonary vasoconstriction. So for pulmonary hypertension, you know from the board classification that can be idiopathic, can be because of the left heart diseases, chronic lung diseases, chronic pulmonary thromboembolism, and multifactorial. So in a pulmonary artery pressure, as we talked, so then systolic stay the same, but diastolic increase, and then we have a dicritic notch. That is the time that we have the closure of the pulmonary valve. So for the pulmonary artery pressure tracing, it's very close to the right atrial pressure. So we have a dicritic notch, and then that's the time that, if you remember, for the right atrium, we had the A and C was the time that tricuspid valve closed. Here is the time that pulmonary valve closed. So for the pulmonary wedge pressure or pathologic wedge pressure, so there are many things that can affect our pulmonary artery pressure and wedge pressure. That's why when you pay attention, when you take care of the patient, think about it before you say if their wedge pressure is high or low, or maybe it's a false number. So the best thing is that patient stay in a supine position and catheter be in a zone 3. So the zone 3, we have 3 different zones in a lung. Anybody remember about those 3 zones in a lung? So based on the patient in a sitting or supine position, in zone 1, the alveolar pressure is more than pulmonary artery pressure, is more than pulmonary vein. In zone 2, pulmonary artery more than alveolar, more than pulmonary vein. In zone 3, pulmonary artery more than pulmonary vein, more than alveolar pressure. Why we want to be in zone 3? Because you want to remove the alveolar pressure, because if the alveolar pressure be high, it's going to affect of the number that you get from the wedge pressure. So the problem with the wedge pressure is that's the reason that we don't think that pulmonary wedge pressure is equal to the volume in the left ventricular, because left ventricular, the main thing is to assess the patient is that left ventricular and diastolic volume, because cardiac output is the stroke volume times the heart rate, correct? So left ventricular and diastolic volume is the volume that affects on the stroke volume. So we assume that left ventricular and diastolic volume is going to be equal to the left and diastolic pressure. Left and diastolic pressure would be equal to the wedge pressure, and wedge pressure is reflecting on the left side because we cannot directly measure the left side. But as you see, there are lots of the assumptions. So first, pressure is not equal to volume. Second, we have a different valve between. For example, if the patient has a mitral stenosis, or if the patient has a mitral regurgitation, or if the patient has an aortic regurgitation, or if the patient has a left ventricle that is stiff. So many things affect on the left side. Meantime, this left, the heart and lung in the chest, they are talking with each other. Many things can affect also on the pulmonary artery, or many things can affect on the chest pressure. So that's the reason that when we get the number, we should pay attention that if this is the right number or the changing by the different factor. So normal wedge pressure is 6 to 15. So reflecting of left atrial pressure does not directly measure end diastolic pressure, and as I talked, left ventricular compliance is important. So we talk about that one. So abnormal wedge pressure is that when the wedge pressure is elevated, we can, if there's a left ventricular failure, if the patient has a mitral valve disorder, if it's a hypertrophic cardiomyopathy, hypervolemia, right to left shunt, and tamponade, constrictive and restrictive cardiomyopathy. And low wedge pressure can be hypovolemia, can be because of large PE or veno-occlusive disease. So the condition that wedge pressure can be more than diastolic pressure, that's the thing that there's a factor that can affect our number. If the patient has a mitral stenosis or patient has a left atrial tumor, myxoma, PE, mitral valve regurgitation, they can increase the wedge pressure. Or the wedge pressure is low because the left ventricular diastolic pressure is high, then the left ventricular compliance is decreased, or then the diastolic pressure is high, or the patient has an aortic valve regurgitation. And the condition that they have a more difference between 1 to 4 as like increased vascular resistance in the pulmonary artery, pulmonary hypertension, cor pulmonale, PE, and Eisenmenger syndrome. So the same thing we talk about the CVP tracing that can be abnormal, PA wave also can be abnormal. So we can have a large A wave in a MS when the patient has a left volume overload or left ventricular dysfunction. And we can have a large V wave that in a MR. We had a large V wave in a TR also, if you remember, in a CVP. So in a pulmonary artery, also large V wave is in a MR. But actually, I thought I put these two pictures because this is after they start the nitroprusside, and you see that the MR gets less because after load reduction and the V wave change. So in cardiac tamponade, there is an equalization of diastolic pressure, and we have a loss of the V. In a constrictive pericarditis, we have an equalization of diastolic pressure, but the difference is that actually is exaggerated of the Y descent. So I put it at the side by side. So pericarditis and the tamponade. Now we are talking about arterial line. So what is the arterial line? It's a cannula into an artery to continuously measure systolic blood pressure, diastolic blood pressure, and MAP. A cannula detects the flow and pressure with the contraction of the heart, and mechanical pressure transmitted through the cannula into the fluid-filled rigid tubing and up to the transducer. The transducer converts mechanical pressure to the kinetic energy, and kinetic energy transmitted to the monitor and graphically displayed so we can see the tracing. So both numerical pressure and we can have a atrial valve form. This is the A line. I'm sure all you see that the A line before. So the tracing on the A line has 4 different parts. So the part of is a peak systolic pressure, and this is the dichrotic notch that we need the aortic valve closed, and we have a diastolic pressure, and the part 4 is the anocryt notch. That the peak systolic, it reflects maximum left ventricular systolic pressure, beginning with the opening of aortic valve, sharp up, and rise reflect the outflow of the blood flow into the arterial system. Dichrotic notch, here, blood flow attempt is a closing of the aortic valve, and blood flow attempt to equalize by flowing backward causes the aortic valve to close. Diastolic pressure that reflects the level of the vessel record or amount of the vasoconstriction. And then anocryt notch is the first phase of ventricular systole, is a volumetric contraction. So pulse pressure is the difference between systolic and diastolic. So that the things that affect on the pulse pressure is a stroke volume and vascular compliance, widening pulse pressure in an AR, and narrow pulse pressure we can see in an AS actually, or tamponade or cardiogenic shock, massive PE tension pneumothorax. So for arterial line weight, I'm sure we are hopefully you remember from the past, we have a pulsus alternans that during the sinus rhythm, regular alternating pattern of change in the peak systolic pressure may alteration in calcium or myocardial muscle fibers. Pulsus paradoxus, there's a change in the inspiration and expiration. During the inspiration, lower intrathoracic pressure, increased pooling of the blood into the pulmonary vascular, then less blood into the left side of the heart. On expiration, blood was pulled into the pulmonary base, shunted to the left heart, and if it's greater than 10 millimeter of mercury, the difference can cause the pulsus paradoxus when you see in tamponade or adhesive pericarditis or severe lung disease. In aortic stenosis, I told you about the pulse pressure is narrow and can cause result of the slower ventricle ejection fraction. So that is aortic insufficiency, wide pulse pressure, and then making higher systolic pressure during the next systolic, while during the diastolic, the left ventricular receive more backflow blood volume. And in the atrial fibrillation, we have the irregular. So for the A-line accuracy, the thing that I want to talk about is patency of the line, leveling, zeroing, and square wave. So for the leveling is that you need to align the transducer with the tip of the invasive catheter and minimize the effect of the hydrostatic pressure on the transducer. If position too low, the fluid within the tubing is high, so then you get an abnormal high pressure. If the position is too high, you're getting abnormal low pressure. And the zeroing the transducer. So how you level the transducer, that there should be, the right atrium is that the way that you can, is between the anterior axillary line and the posterior axillary line in the middle of that, so mid-axillary line and a fourth intercostal. The thing that we need to know is a score wave tracing, that we do a fast flash and sharp of a stroke terminates in the flat line, followed by immediate rapid down-stroke low baseline. So normal is 1 or 2 oscillation, and then quick to the baseline. But if it's an overdamping, actually what it does, decrease the systolic blood pressure and increase the diastolic pressure. So then shorten the pulse pressure. And when it happens, if we have a clot or air bubbles in the catheter, and or is the kinking in the catheter, or if the tube be rigid. In the underdamp waveform with more than 3 oscillation, and what it does is increase the systolic blood pressure and decrease the diastolic pressure and increase the pulse pressure, and usually related to the length of the tubing or the multiple stopcock, and sometimes tachycardia and high cardiac output can cause that. The other thing I want to show you about the tracing, the A-line change from the aorta to the peripheral. So the further from the aorta, we get a taller systolic peak, further dicrotic notch. So the systolic is get taller and the dicrotic notch is get further, and the lower the end diastolic. But map doesn't change. Thank you. So if you have any questions, any other camper? Okay. Thank you. Which one?